Okay, so welcome everyone to our session on incorporating peer recovery support specialists into substance use disorder and MAT treatment and billing Medi-Cal 2. We're going to touch just probably a tiny bit on that, although I know that's a really, really important part of your world, so we will get to it. I am super happy to be introducing this session. One of the other hats that I wear, in addition to being the project director of the Hub and Spoke project, is also to be the project director for the Behavioral Health Workforce Development Project, BHWD. And one of the things that we're doing under that line of work is rolling out peer recovery support specialists. California is the 48th state to actually develop peer recovery support state specialist certification. So we're not exactly early adopters on that one, but we can learn from other people's mistakes. We can also learn from what everyone else has been doing. And one of the people that can tell us what everyone else has been doing is nobody other than Philip Rutherford, who is with Faces and Voices of Recovery, which was one of the sponsors of yesterday's Recovery Happens event, and has been working in 38 other states to roll out certifications of their peer specialist programming. I have a long bio here that I should be reading you about him, but I'll just say that he's the Chief Operating Officer at Faces and Voices of Recovery, also sometimes known as Favor. He's a recovery coach, a passionate member of the recovery community. He has been a fabulous resource for us in increasingly supporting our programming and our other peer folks with a lot of technical assistance and training. And he's been, as the COO at Favor, he has been really, really pivotal in rolling out the conception, design, launch, and facilitation of the Recovery Data Platform, RDP, which many of you may know about different kinds of electronic health records. And everyone kind of goes to sleep when I say electronic health records. On the other hand, it is really important. And it's really important to have a good one that is relevant to programming. I am an epidemiologist by training, so data is kind of a thing I just happen to love, but it will really help you to demonstrate the efficacy of your programs, which I know are efficacious, but if you know it and I know it and there's no data behind it, don't even ask for money, because you're going to have some sort of, you're going to have something to tell us about that. So Phil's got a background in psychology. He's worked with a specialization in substance use disorders. He's been a member of a number of committees at the National Institute of Health, FDA, other federal agencies. He hails from Minnesota, but he's actually spending a lot more time out here because his daughters have been in school in Los Angeles. So kudos to his daughters for bringing Phil to the West Coast. And our second presenter, who I will just introduce right now, is who will follow on with Phil's presentation, is Lucero Robles. She's an LCSW pretty in pink in the back of the room, and Lucero is fabulous. She works at Cal Mesa, the California Mental Health Services agency, and she's the director of quality assurance and compliance. And she has been doing amazing work to actually get the whole peer certification rolled out, which is a giant, giant process, and working with a lot of different counties to roll this out. She comes over to us from Monterey County, where she had served as the interim behavioral health director there before she came to Cal Mesa. And she's been doing just terrific work. So she will be somebody that if you're working with peer recovery support specialists, you will look at the product of her work on the Cal Mesa website, which is just loaded with great information. And she will be sharing some of that with you. So I'm really excited to have them both here today. So I'm going to give the lab to Phil. And
anyone else here get weirded out when you hear your bio? I get a little weirded out when I hear that. I'm not sure who they're talking about. I guess that's me. Hi everyone, my name is Phil Rutherford. I'm the Chief Operating Officer at Faces and Voices of Recovery. I'm very excited to be here. First things first, I usually introduce myself as I say, hi, my name's Phil. I'm a Black man living in long-term recovery. And what that means to me is that today I get to participate in my life in a way that I was not certain was possible. Now, you guys look like a bright bunch. You probably figured out that I was Black before I said that, right? I won't do a show of hands, but I say that for a very important reason. My recovery story centers around some failed attempts, and a lot of those attempts, I'm certain that they had something to do with maybe not finding the right services, but I never really found people that look like me. I went into a lot of recovery spaces and I didn't find programming or people that look like me or that spoke to what my recovery experience or what my addiction experience looked like. So I introduced myself that way, and usually someone in the room is like, what? No shit, you're Black. So anyway, okay. So sorry. So we'll start with that. I like to do a who's who because I want to know in the room who here has worked directly with someone that has done peer support. Okay, good. Who here has been doing that work for more than 5 years? 5 years, okay. 10 years? 15 years? Would you like to come up and give the, okay, no, okay. No, okay. And so I asked that because we're gonna talk about peer support in a very sort of, I'm going to start at a baseline. So for those of you that have been doing it for a while, please bear with me. I'm not trying to tell you stuff that you probably already know, but we need to start at kind of a baseline for everybody to get understanding. Does that make sense? So if I'm telling you stuff that you already know, please don't walk out in disgust. Just bear with me. Okay. You guys have probably seen this slide already. I don't have any affiliations. I do aspire to having some kind of like financial thing going on in the background where one day I have to disclose my affiliations. I aspire to that. But currently I do not have any of those. So, and I'm not trying to make light of it. It is important to make sure we keep those lines clear. So, but I don't have any of those. But I do aspire. So if anybody wants to talk after, let's get biomed, biotech money. Yeah, that's private equity you want to, okay. Here we go. It is National Recovery Month. I'm super excited. I was at the event yesterday in front of the Capitol. September is usually really busy for me. I get to go around the country, and it's one of the benefits of being in recovery. I get to see all across the country. I get to see people practicing their recovery and living their recovery out loud, and that's something that I'm really grateful for. So, this is what I'm here to talk about. Oh, sorry. Bear with me a second. I need to go back a few slides and cover my topic. So my topic is going to be integrating peer support into SUD and MAT treatment and Medi-Cal too. I'm not going to talk a lot about Medi-Cal. Medi-Cal is not my area of expertise, but certainly integrating peer support and SUD into MAT treatment is something that at Faces and Voices we've done a lot of work around. Learning objectives. Hopefully by the time that we're done here, you'll be able to identify a few methods and opportunities for utilizing peer professionals in MAT or MAR recovery programs. Hopefully propose 2 strategies to support peer professionals with best practices and create a mutually beneficial relationship between them and the organizations and the clients served. And hopefully 2 ways to influence organizational attitudes to create an environment where peer professionals are included in policies and procedures. And every session has to have learning objectives, but I think the thing that I would be really happy if everyone walks away from here with is just the notion or the understanding that engaging and involving people with lived experience in SUD work, specifically around MAT, is critically important. I was in I think I was in the ballroom over there talking about one of the early experiences. I don't do direct peer work anymore, but some years ago I was sitting in an office and doing peer work, and in that county, the probation department would send peers to our organization, even though we told them not to, right? Because hopefully you know that peer and working with people with lived experience and working with peers should never be coercive, right? There really shouldn't be someone saying, you better go do this, you better go work with peers. But that's precisely what the probation department in this county was doing. They would say, you got to go talk to Phil, right? And so a guy came in and sat down, and I said, what do you need? Why are you here? And he's like, my probation officer said, I got to come talk to you. Great. And I said, well, what's going on? And he said, well, I lost my job. I don't have a place to stay. Don't have a car. All the, lots of, I don't say social determinants of health because I say structural determinants of health, but a lot of the structural determinants of health markers for him were bad. And he said, I don't know what I'm gonna do. And so we talked a little bit more, and I got a call later from a probation officer asking about him. And I'm like, well, what did he tell you? And they said, well, we don't know what's wrong with him, but he keeps giving positive UAs. He keeps, every time he comes, he gives a positive UA. We don't want to send him back to jail. We don't know what to do. We don't understand because he's got a job, he's got a car, he's got a house, he's got all these things. And he's got all the things that when we look at our structural determinants of health, he looks like he should be killing it, but he's not. And we don't understand. We're curious if you have any insight. And I didn't rat him out, but I did say, hey, you should probably go back and talk to him. And that's the value of engaging peers in work. So that's the thing that I really want you guys to leave with, is just the notion that sometimes, even with the best of intentions, you'll get better results having someone interact with a peer. And I see him getting head nods from the lady who's been doing it a long time. So I'll go with that. Yes, also thumbs up. Please do that. I like positive affirmations. I'm very good with that. I don't know if you're doing evaluations after this. I'll give you some adjectives at the end of the session that I'd like you to use. But for a second, I want you guys to imagine a world where the community in which you live in has access to organizations, people that can help fill gaps of service. Now, some people already live in this world, by the way. There are some people that go through their life and when they need something, they reach out, someone's there to help them and all of that. I don't know if you guys are working with clients in that situation. Is anyone working here where their communities are fully resourced? Anyone? They have a substance use disorder problem. They raise their hand for help. Someone's there for them. They don't have to wait for a treatment bed. They go into treatment or whatever service they need. And that world does exist, by the way. It does exist all over the place. But there's an income strata question, which I don't want. That's not the topic of my discussion today. But there's a certain income and insurance level at which, when you need help, you get help, right? But let's imagine that was available for everyone. Let's imagine that not just that was available, but that the community really embraced that the community really supported it. One of the things that I've been on for the past couple of years is the notion, and I'm measuring my words, but this thought process around, even in the recovery space, culturally competent services needing to be available for everyone, not just for a particular dominant culture group, right? It's like I said, it's part of my recovery. It's part of my recovery story, but delivering those resources into communities, specifically marginalized ones, where that has never been the story. It's an important thing, and so we're just brainstorming here. We're imagining a beautiful place. I'm sorry. Okay, from the audience, I'm saying this for the recording. An audience member said, "Not just white people." So that was the audience member's feedback. Yeah, it's good. And so you get the idea, right? The reason I'm talking about this is actually the next slide, and that is that something like this has been happening. There have been some measure of lived experience and peer resources available to some, right? And assuming that 12-step is a thing that can work for you. And I'm full disclosure, I am a 12-step product. but I also recognize some of the severe limitations of 12-step methodology. So I've been around. We have a saying in that particular fellowship that if you stick around long enough, you'll understand why it doesn't work for everyone, right? So there's some limitations there, but the business of getting people to treatment, getting people housing, getting people jobs, social services stuff, that's actually been going on for quite a while in some of the 12-step communities. Now, again, they're not regulated. There are all sorts of things that come up in an unregulated care system that you can't legislate. But some of this has been happening in those places. Who here knows who Bill White is? Does that name mean anything to anyone? No, that's Chuck C, but a wonderful book nonetheless. So Bill White is a recovery historian. He's someone that since about, I guess, the late 90s has been researching and kind of studying recovery movements. So yes, there's AA started in the the mid to late 30s. Yes. Prior to that, there was a group called the Washingtonians. There was an abstinence-based group, and there have been other movements in American history focused on recovery. But he studied all that. And he's kind of for recovery folks, he's kind of like our guy, right? He's sort of our historian. But I'm going to read you a quote from him because I think it's particularly powerful. Recovery support roles that emerge with very close connections to communities of recovery are prone to disconnect from those communities over time, as the persons filling those roles come to see the primary source of their power and authority coming from within themselves and from their professional organizations. And that's important because I assume that everyone and we didn't do like people's job roles because I don't have that much time, but I am assuming that everyone here is working in a professional capacity to help people with various components of housing, behavioral health, so on and so forth, right? The challenge with the 12-step methodology is that the very nature of it tends to pull people away from professional services. And there gets to be this kind of us and them mentality, which I don't know if you guys have seen that in your work. The peer work, though, professional peer work as done by someone that is certified, so certification is a thing in California, right? As of July 1. This means yes? Yes. That work is particularly useful because a lot of times these folks have used some of these systems. They've gone to similar meetings. In a lot of cases, back to peers. So you've worked a lot with peers, right? Oh, you are a peer. Okay, but you work with peers.
I was the first peer advocate ever hired at California.
So your interaction with people seeking recovery in your area, as you look through this list, do you agree, disagree with some of these statements?
Peers have used the same service, agree, run to the same meeting, met with the same people, agree, and so on. I think that one is kind of iffy because not everyone knows their leader.
Mm-hmm.
But I have to say that.
Yep, and that's actually why that one's bolded in places. So, and by the way, you guys, yes, you're the 48th state to adopt these, but you're not last. Okay, you're not last. I'm not going to shame the other states that are 49 and 50, but in states where peer has been going on for a while, like professional peer work has been going on for a while, there is a robust network of advocates that as people come in, like we'll talk about Minnesota, where I live. That's part of, in addition to people getting the basic peer training, like, hey, here's how you talk to someone with suicidal ideation, or here's how you talk to someone about getting a GED. Part of that training in Minnesota is, here's how you find who your city, county, state representative is. Here's how you connect with them. Here's a way to organize and advocate. And that over time, we see that happening in states as the peer movement gets a little bit more developed. And it's an important part. I mean, the peer advocacy in California actually moved the needle. It changed things from what was largely a clinical model to something that includes and places a premium on lived experience. So thank you. Yeah. Say more about that.
Well, I'm a peer myself, and where I'm at, we're still have hierarchy, top-down leadership, and they really keep me under the bus. But I know for myself that I have to keep advocating for what I know is right in the peer opinion, and eventually it'll come along. I think that our leaders need more training to understand who peers are and what they actually do, instead of looking down on them because they have a master's degree or a PhD. Because I do the work.
Yeah.
I really do the work.
And maybe
Yep.
we go as far as like 2 years in those leadership roles.
Yep.
Not just somebody higher up understands it's taking years.
Right, and telling me I don't know because I don't have my master's, that's ridiculous. I got lived experience.
Yep.
I feel the pain of everybody out there.
Okay, that's good. I like it when people get fired up. You're gonna have me. I'm gonna be up here preaching in a minute. It's like let me tell you. No, so anyway, I hear you, and that's a consistent thing. And I apologize, Ben. I know I'm supposed. You're okay. Thank you, because I'm supposed to repeat. Yeah, I'm supposed to repeat what is said, and that was too much to repeat. But I think the summary of what you said is that there may be a disconnect between the respect accorded to someone with a master's degree and the respect to someone that.
Interdisciplinary team, that's what I'm a part of.
Mm-hmm.
So yeah, me coming on board, she's with that lived experience. Right. And you know, my supervisor was like, you're gonna really make it in mental health if you have a master's degree. I said, well, I think I just need to common sense. That's all. I just need to go out there and engage and make a connection with somebody, not just pass it on.
Sure. Sure.
That's basically a stigma.
Yeah, and stigma's a real thing. That's one of the reasons for existence for Faces and Voices of Recovery is stigma busting, right? The original. So we started in 2001. The entire point for Faces and Voices existence in 2001 was to put a face and a voice to recovery, because we believe that there is plenty of information in the public space about addiction, right? Just about everyone knows or thinks they know what addiction is. I might disagree with that, but there's plenty of information about that, not as much information about recovery. Yes, ma'am.
I may not be saying that, but I saw that on the first share. I thought he was the CEO of Faces and Voices of Recovery.
Mm-hmm.
I think that says it all right there. That every one of us has a story, and I have a face.
Yep.
To my story.
Yep.
And in the program of 12 steps, I love Alcoholics Anonymous, just for the record, but I also can see where we need to be adaptable and mesh things, medical versus recovery model versus medical model, how we, through the years, we've had to mesh.
Mm-hmm.
But as we come together as a human race, and I'm not going to stop talking about the human race because that's who we are, and I think I take most pride in the work that I started years and years ago. And that was, as I learned yesterday, that it's not really so much about cultural competence, because I'm not there. It's about keeping myself humble and walking in cultural humility. And I want to just highlight back to connections, because I think that's kind of like, I want to point to him too. I got so much out of this workshop today. Go back to you.
Sure. Yep, and also I won't, you got that right, Ben? Perfect, thank you. Well, I don't want to try and summarize it because I might miss something, I might miss a point. So let's talk about, just real quick, multiple pathways of recovery. You guys heard that language? Super important, also a tenet. Like if there are 2 or 3 tenets to Faces and Voices of Recovery, face and voice, stigma busting, and multiple pathways, right? We hold no pathway to recovery in any higher esteem than another. Someone wants strict kind of 1930s AA, great. Someone wants competitive macrame, great. We don't. It is a thing, by the way. Competitive macrame is a thing. So just some kind of generalized information about community-based services. This is information that you guys probably already know, but research suggests that providing holistic community-based support enhances treatment outcomes. And it's kind of a, we call these statements, right? Like if you help someone, if you support someone with their housing, and you support someone with an ability to gain employment, and you support someone with a variety of all of the things, all of the components of basic living, they tend to do better than if you do none of that, right? So it's kind of, that's why we call them statements, because it's kind of basic information. And but luckily, research supports that. We also know that the community, I think one of the other components of peer support, and specifically peer support in this type of work, is that people can do a lot of work in treatment. And treatment, treatment is very important. It was extremely important to me because the 7th time I went, I really nailed down some stuff. But recovery typically happens in the community. So I benefited from my experience in treatment, but I recovered in my community. I recovered with community-based resources and I mentioned that I finally found a group of men that kind of looked like me. Some of their experience was similar to mine, and that made a difference for me. It made it easier for me to recover. So you guys know this data, and let's see if I have to click again to make it show. Absolutely. So, and again, you guys, how about the name Dr. John Kelly, Mass General Hospital Recovery Research Institute? Does that mean anything to you guys? Okay, there's a gentleman that's like Bill White is kind of the recovery movement's historian. Dr. Kelly is conceivably our researcher. But this and other research around recovery shows that the early inception, right? So someone moves out of pre-contemplation into contemplation and heads toward action. This typically takes time. On his work, and he studied people coming in and out of recovery community centers in the Northeast. He said that it took longer than 5 years. He said it took about 7 years for someone to maintain 1 year of abstinence. This year, and he was scaling abstinence, so that's a little bit different. But this slide looks at 3 to 5 years at its high point. The point is, and again, information you guys probably already have, when someone decides that they want to stop use or alter their use the first time, it is not always successful and done. Is that surprising information to anyone? No? Okay, I didn't think so. So let's talk about different types of peer recovery support or recovery support services. So the obvious one that people sort of think of is emotional support. Informational support, though, equally important, right? Where to get stuff, where and how to do things. There's a lady named Dr. Ruby Payne who's done a lot of work on poverty, and she says that one of the most important assets that people have is knowledge, right? That yes, there's money and resources that change hands in families, right, over generations. But way more important than that is the intergenerational transformation and passing of knowledge. Peers can help with that. Peers can help with knowledge of systems. You guys have probably already seen some, if you work with peers, you've probably already seen some of that. So I said a bunch of fancy words. I'll say it in a much simpler way, the plug, right? Peers know where the plug is. They know how to go and get stuff that you need, right? And that's informational support. Instrumental support, that would be concrete assistance in helping others get stuff done, and then affiliating support, that connection to social group. Rat Park, anyone know that experiment? The Rat Park experiment? Okay, I'll tell you an experiment you probably do know. You put a rat in a cage and you give them a little lever and they can get cocaine if they press the lever. What do? They probably salivate at first, but do they press the lever or not? Yes, and then what happens? They keep pressing it, right? Until they die. Okay, Rat Park was an experiment designed, same model. The rats get addicted to different substances. I think they've done this, they've replicated it with cocaine and heroin, and I want to say alcohol, but don't quote me on that. I know cocaine and heroin. Same model. Press the button, get the drug. They show signs of dependence, tolerance. They got classical signs of SUD. But this researcher introduced another variable, and that variable was prosocial rat activities. I have no idea what, I don't know if they're like rat baseball. I don't know what the prosocial activities are, but I do know that, and it's some sort of outrageous number, like 95% of the rats over time shows the prosocial behavior rather than the drug, right? And I'm not making it up. Look, you can look up Rat Park. There is a lot of data surrounding the social and sort of contextual relationships that happen with peers. And that's yet another reason to try and connect people with peers, because they can get that. Rat Park, I have a group of friends that when we get together, we call it Gathering of the Rats, right? So, because that's, yeah, so. Yep. So for those, and again, I just want to do a quick temperature check. So those of you that, and I tend to look at, like, people say they know peers, I tend to make eye contact with them. And I know we're vibing. Let's talk about people that know absolutely nothing about peers. Does what I'm saying make sense? Are you with me? What do you need, new or more information? Pace is good. I only have 10 minutes. Nice. All right. So the reason I asked that is I'm going to talk through some peer support activities, things that people do when they're practicing peer support. One of them is advocating for people in recovery, sharing resources, building skills, building community relationships, so on and so forth. But again, that sense of belonging is the one thing. And I went from, I used to, most of my work prior to about 2012, I was private sector. So I didn't really know a lot about this. In 2012, I determined that I was having more fun working with people in recovery than what I was doing in private sector. And I worked for a couple of tech and marketing firms. And so when I made the shift, the thing that I've noticed most consistently about peer work is that there is something that happens when a person with lived experience is sitting across the table from another person who wants to get better. And it is almost impossible to duplicate it. We've done research on people coming into and coming out of peer recovery centers. In fact, we have a data product called Recovery Data Platform. I think she said it in that bio, which I really should change. I want it to be shorter and tighter. It's too much. But we've been tracking people coming into and out of peer recovery programs across the country since 2017. Our data is absolutely clear when someone connects with a peer and stays with them for more than 6 weeks, their outcomes are dramatically better than someone who doesn't. It's another Dutch chart, right? We have a chart that has like goes one way for people connected with peers, one way for people that connect for a minute and then go away. So we know for a fact that these activities are meaningful to people with substance use disorder. Some other activities, providing services or training, developing resources, sometimes supervising. Now in your model, you guys will have to educate me. In your model, is your supervisor clinical or are they a peer? They're clinical, but they can be a peer. They just have. But okay. Okay. So, but the letter, and you'll cover this, right? So I can leave this alone. But I will say that in some states, there is space left for peers to supervise peers for the very reason that you described, which is sort of understanding the peer role and making it make sense, right? And we're doing questions at the end, right? Okay.
How long is Lucero's presentation?
Yeah.
We have like 25 minutes left.
Okay, I'm almost done with these slides. I'll be done. Gonna get the hook here.
I wanted to stay away.
Okay. So just a couple more things where we think peer support can be helpful. Preceding formal treatment, like a lot of people think about peers too as the space after treatment, right? Like you go to treatment and then you go after. I'm on the board of an organization in Minnesota. It's called Docs Recovery House. I will plug them. We do pre-treatment. So at the point that someone receives a diagnosis that they have SUD, they can come into our facility and sleep. And we do that for a very important reason because, and I apologize if this doesn't make sense to you, but sometimes when people say they want to go to treatment, like the next morning, they don't. And not only they don't, they're not gonna. And there's nothing you can say is gonna make it happen. But what we do at Doc's House is the minute they say that, the minute they get that diagnosis, so they do have to get diagnosed somewhere. But the minute they do that, we give them a bed. And they stay, and not only do we give them a bed, we give them peer support services that day, right? Because it does that. Now, it's not bad news to us because it's okay, but we're all private funding, right? We've done fundraising and we sell recovery support services to private businesses and all that, but it's difficult to do on government funding, but it is a very successful program because again, people come in there and then so they come in, they get a bed, they get peer services, they go out to treatment. When they get out of treatment, they come back and they deliver peer services. Part of the deal is you go to treatment, you have your time away, you come back, you deliver support services to people that are coming in. So that's a thing that they can do. They can help during treatment. They can do after treatment. They can do completely separate for treatment. You guys probably know there are some people that are never going to treatment. No matter what you tell them, no matter what you do, they're just not gonna. Peers can be really useful in that space too, right? They can be helpful and just maybe help. Maybe they just need to get a different recovery pathway or something that is more suitable to them. I'm almost done, I promise. Peers aware of what's happening in the community. They know where to go, what to do. They know about the plug. If you don't know what the plug is about, I'll tell you after in questions. As it pertains to supervision, there are a lot of good reasons to do this, but I think the most important one is that there's a lot of good reason to have peers act as supervisors, but supervision is important because the role of the peer is sometimes new to organizations and they don't know what it is. Because there used to be something called a treatment tech. And I don't know if you guys had those here, but a treatment tech is someone that like drives people to meetings or they take people to the park or whatever. that's not what a peer worker is for. A peer worker is there to leverage their lived experience in attaining recovery and share that with the next person, or maybe share some specific resources with them. So having a peer get good supervision, it's really important to make sure that both the supervisor and the peer understand that and can offer some guidance around that. It's also a good ethical thing. There's some ethical challenges that come up. Right? Ethical challenges come up with humans, definitely with working with peers and people new to SUD recovery. We recommend when organizations say, hey, I want a peer, we work with some larger organizations, say, hey, we want to institute peer stuff in our place. We always recommend 2. Like, it's kind of like in 12-step, they have a thing called the 12-step calls where you go show up to help someone. You always go with 2 people. Same thing with peers in an organization. We want 2 because one is very lonely, and it's not. We don't believe our experience is it's not. Not only is it not good for the organization, it's sometimes not good for the peer themselves. And we have to remember that peers are also people with SUD and need support as well. There's plenty of benefits. I think I probably already talked about a bunch of benefits, but you'll get the slides later. Did that. No wrong door. We really believe that the most important thing, if you look at behavioral health, is that we get people the help. I can't tell you the number of systems that I've been engaged in where we find out at the end of the day, it's that someone didn't get the right referral, as opposed to, come on in, we got you, right? That's kind of the sort of the spirit of Doc's House is, we got you, come on, we got you. What's that? You need a ride to your assessment? Come on, we got you. So here's some ways to get peers in on the action, coordinating events, team and staff meetings. You guys can read, or you can also just ask, right? So how many people, let's go back to show of hands, how many people know a peer or know someone that does peer work? You can also ask them for additional resources. You can say, hey, do you know any other peers? What peer groups are you associated with? Are you part of any memberships? How'd you get to be a peer? Like, there's a way to sort of proliferate the peer community just by word of mouth, just like kind of the same way we used to do sales, right? Who do you know? Write down, give me 5 names of people you know, and then you got to call them all. So you guys have seen this phrase. We mean that. we even at the federal level, we mean that. Okay, that's it for me. Thanks. And I'll come back for questions.
Okay, sorry about that. All right, so good afternoon, everyone. My name is Lucero Robles, and I'm a licensed clinical social worker. And I am working at the California Mental Health Services Authority, and we are a joint powers authority. So we represent the county behavioral health plan, so both the mental health side and the substance use disorder side. So as you guys all are aware of the implementation of SB 803, you guys were probably a part of that in terms of advocacy, right? 3 bills or so before it was passed, right? And it wasn't everything everybody wanted. You know, that's how it is, right? Sorry. I like to have this slide available because it gives people an opportunity to kind of see the Medi-Cal world in California. It's a little bit different than other states, right? Here in California, you have the federal government who delegates responsibility to the state, and that's the Department of Healthcare Service. The Department of Healthcare Service and delegates that responsibility to counties. We have 58 counties in California. That's a lot of counties. It's a lot of people. And that's a lot of work to be done. What's important here to know is that the Senate bill, those are the lawmakers. Those are the people that made the law. They say this is what should happen. The State Department says, here are the standards that we will follow in California. The counties say it's an optional benefit for counties, by the way. They say, I'm going to implement that in my county. Other counties are saying, I'm going to wait a little bit longer. And then Cal Mesa comes in terms of the certifying entity. So perhaps Phil can speak a little bit about like some of the other states. They do it very different than we do here in California. In California, there are different agencies and training entities that provide training and certification and exam and all the things. So we have an opportunity here in California, being the 48th state, to implement peer certification. We have an opportunity to kind of learn from that. And also, you guys would understand this a little bit more. On the SUD side, you remember we had a lot of certifying entities and they went belly up and then lots of chaos happened, right? Thinking about like, what can we learn from those experiences? The county said, what if we have one certifying entity? Cal Mesa, our organization, develops and builds programs either locally for counties, regionally, or statewide. This is an example of a statewide program that we are implementing on behalf of counties. All right, let me know if I'm going too fast. I'm trying to get it all. I'll talk a little bit about, I'll skim a little bit about what the certifying entity is. You guys probably work with alcohol and drug counselors. You have a certifying entity. There's certain requirements that need to be met. They go to one of the 3 certifying bodies, and then they said, I've done my training, please give me my certification. So very similar in that sense. Cal Mesa is developing the statewide exam. It's almost ready. Yeah. So, and of course, there are the individual people, yourselves, and maybe other people that you know who actually want to be certified as a peer support specialist here in California. All right. This slide is important for me because oftentimes there's a little bit of confusion, especially if you've been following the peer recovery movement, which you have, and the certification in other states. In California, we have one certification for either or both mental health and substance use disorder. They're not separate, it's one. That for me is an important part because sometimes people also get confused or unclear about the specializations. So not only we have one certification for medical health peer support specialists and 4 certifications. And here are the 4 certifications. The parent, caregiver, family member, peer. I just realized I'm still wearing this. Sorry about that, guys. The parent, family member, peer is the specialization that needed to be rolled out at the same time as the certification. So that specialization, the curriculum is posted on the Cal Mesa website, which by the way is capeercertification.org. So it's a website completely dedicated to the certification process. And then in the future, by January 1st, 2023, the other 3 specializations must be present. And what that means for us is that we will hold a focus group to establish the curriculum for these individuals who work with people who are unhoused, people who are working with persons who are in crisis, and people who are working with people who are involved in the criminal justice system. All right, I told you a little bit about our role based on our time. You know, there's a new code of ethics. I think that's an important piece to remind ourselves. So that's available. And there are, so those are obviously based on the values of peer work. This just talks about the certifying entity. So one of the things that we did at Cal Mesa was establish a stakeholder advisory council. And we did that early on in order to maintain the peer voice and to ensure that we're building a program that makes sense in terms of what a peer does and their value and what they bring to the table, which is themselves and their skill set. And I love that, the plug, like I need to use that. My favorite thing. I'm from LA, so I know what that means. So, so we have, you know, stakeholder advisory council meeting. Those are open to the public on Zoom, you know, you can just show up. And then, so we have members all across California. We have about 18 members. For the exam, as well as the policy development, we use subject matter experts to design that for the program, to design the exam. Subject matter experts from substance use, from mental health, from behavioral health, from California, from out of state. Like we really try to get a collective voice to make sure that we have an exam that is meaningful and training, of course, that is meaningful. So as a certifying entity, we certify the individual, right? A person will register on our website. They'll ask to sit for the exam. They'll demonstrate they meet the minimum requirements, which we'll talk about, those two different pathways. And then they sit for the exam. The exam is 120 questions, 2 hours and a half to take. There's a 10-minute break in between, and multiple choice, and it's an online proctoring, live proctoring. Multiple choice. No, multiple choice, and we do have a prep guide that is available on our website. Again, thinking about lessons learned, the data collection component is an important part. We heard, our sponsor today, talk about the importance of data. So we need that. We've learned from other states. Again, thinking about all the different agencies or entities that are certifying people. And then we've also learned from our local SUD. So we at Cal Mesa are developing a certification registry. So again, we have one website, all the information, certificate and registry, so that public facing information will be available. So you can go check at any time whether a person holds a valid certification. And of course, Phil spoke about outcomes. So this, again, another area where we can collect information about who is being certified. Did they work before? Are they working after certification? What populations are they working with? So we'll be able to evaluate the outcomes of the people they serve as well. Let's see, Code of Ethics, of course, this project is new, so we appreciate your patience. We are doing our very, very best to get it right the first time, whatever that means, because I think there's always a continuous quality improvement. It's just how it works. It's iterative. We're going to get it right, hopefully most of the way, and then we modify it along the way. So we're open to feedback. All right. So in terms of requirements, so everything you see here is what every single person regarding a pathway. By pathway, I mean if you're going to be certified through the grandparenting pathway or through the what we call initial certification, which requires the 80-hour training by an approved training entity. So I won't read them, but there they are. So just because I get a lot of questions about this particular one, especially with the diploma, high school diploma. These are set by the state, right? So there is advocacy opportunity for the future. Today, this is the requirement. All right, so I just took that same information and put it on that left-hand side, so we don't need to read that. But on the right-hand side, that's your right-hand side, there's the information for the grandparenting process. Again, understanding that that peers have been in the space for a very long time and value their work. And these are the requirements. So they require 1,550 hours to be completed, either paid or unpaid, in a 1-year period of time, or they could do that in a 3-year period of time with 500 of those hours. Very complicated, 500 of those hours in the last 12 months. So they also require that a person be employed on or before January 1st, 2022, so this year, to be grandparented in. A person may apply for a grandparenting process until December 31st, 2022. So until the end of this year, if you qualify under the grandparenting process, you may apply for that. There is a requirement for 20 hours of continuing education, including 6 hours of law and ethics in those 20 hours. You would have completed a training at some point in your career for peer services. And so we would just need some evidence of that. And then 3 letters of recommendation, one from your supervisor, one from a colleague or professional, and then one from yourself. You can write great reviews on yourself. And so again, that's the grandparenting process. And then the initial certification process, again, the stuff on the left, the stuff you've already seen. For you, so let's say you don't have that work experience or one of the other requirements under the grandparenting process, but you're still interested in becoming certified, you can take the 80-hour training from an approved training entity. And then once you've done that, you come to the website, you ask to sit for the exam. We make sure you meet the other requirements. And then then that's that. All right. I feel like I'm running. All right. This could be counted as my exercise. Okay. So we're currently, so Cal Mesa is currently processing applications for persons under the grandparenting and initial, but that have a scholarship. We'll talk a little bit about the scholarship. So the scholarships are funded through the Department of Healthcare Service, and they were given to county behavioral health plans, provided names to Cal Mesa on who or which people can apply under the scholarship. There's only a total of 5,000. So for California, that's not a lot, right? We have a lot of people in California. I think Kathleen can speak to some of the other workforce initiatives and funding opportunities that do provide some funding for certificate that can be used towards certification. So while these are just 500, or I shouldn't say it that way, that's rude. Well, these are 500, that isn't sufficient, we know. So, and then one of the things that we did is to make sure that they didn't go all to mental health, that we divided them up, mental health and SUD, so there could be a combination, there could be some equity there as well. Let's see. So Cal Mesa is administering the scholarships. Again, we receive names from the counties. People go to the website and apply there. We look to see that their name is on the scholarship, and then we approve, depending on the pathway and of course the requirements. I will say we are not currently processing any other applications other than those with scholarship. And the reason for that is that they're time limited in terms of funding. Also, we don't have our fee schedule yet. The fee schedule is something that we get approved through the Department of Healthcare Service, through the state, and we have not received that approval yet. All right, these are just those application dates for certification with scholarship. And then this is my attempt at everything I just said in a nutshell. It's not the prettiest color, but I was trying. All right, but in essence, you register on the website, you complete your application, you meet the requirements there in the middle, and then Cal Mesa will review those applications. Then you may register for the exam and then pass the exam. All right, so in terms of next steps, like I said, we will continue to work on identifying the curriculum requirements for the other specializations. We will update the website for information on certificate registry. So when people become certified, that website, part of it will become available. There's nobody certified right now, so it's not available. The fee schedule says August 2022. That didn't happen, but we're working on that. So that will happen. The exam blueprint, part of it is available on the prep guide. And then we'll put out a full blueprint. The blueprint is the areas of content for the exam, which again, you'll find in the prep guide. And then the exam will be available soon. We do have what we're calling early test takers. You are? Yes. Yeah. Yes, thank you for that. I know, we're waiting for, I think about this all day long. Yeah, I'm waiting to, I think very soon, I think maybe as early as September 23rd, but we'll send you an email with information. Yeah, I just anyway, I just learned that today. Okay, that's one of our staff members. So the exam is coming, and then it'll be available to the general public after that. And then, the exam will be available, right? Initially, it'll be available in English. And then in February, we think, it'll be available in 16 threshold languages as identified by Department of Healthcare Service. That's our website, ca.peercertification.org. You're probably going to have a gazillion questions because I was running path through this. peercertification@calmesa.org is our email. That's our phone number. And, we have a few staff members. We're hiring more staff members to join our team. And predominantly our team is made up of peers. And so we're very happy about that. Yes. Did I do it? Did I do it?
Good question. Lucero.
Yes.
In regards to the December 30th, to have
Oh,
but
yeah.
you extended it. Is that still in effect?
So the question is the deadline to submit an application with a scholarship?
Yeah.
Has it been extended beyond
Yeah.
September 30, 2022? We will likely extend that. It has not been extended yet, but when we do extend it, we kind of like do a line across so people could know it's been extended. Yeah. Yeah, yeah, it's been extended to September 30, but now we're on September whatever now.
Two questions.
Okay.
So the people that are, so the SUV certification, they also like CCAP and CE. That certificate won't count.
Correct.
The ones that-
For this, yes, they can, correct.
Okay. The second question is only through behavioral health, so like ODS, DMC.
For the scholarships, yes.
No, for them to get certified.
No,
So I work
anybody.
at UHC Integrated Clinic. Will, if we get peer support specialists, will they be able to bill that account?
So that's a complicated question. Because, so one of the things that other states do, not California, is that Medicaid is billed differently than it is in Medi-Cal. And Medi-Cal, again, it runs through the county behavioral health plans and other programs that have Medi-Cal billing. But an individual person cannot like send a bill to the state on their own. It doesn't work here in California. It might work in other states. So that was a big shock, I think, for California. So any person can, obviously if they meet the requirement, apply for certification.
Well, we wouldn't be able to bill in the clinics unless we bill the paper.
No. If you're Medi-Cal eligible, so this particular benefit, maybe this is a better answer. This particular benefit is for behavioral health, specialty mental health service component.
So no Medi-Cal managed care plan.
So like I
Correct, not the managed care plan.
have a group of patients in our math program that are peer members that we kind of trained and got them set up. So if we don't have no certification, some of them have those other certifications. We wouldn't be able to employ them in the bill. Or
Can I jump in with this one?
Sure.
So the whole thing is that we're gonna have special services, Medi-Cal codes that will deal with that peer specialists, people who are certified or gonna be able to do. So all of that other stuff, the managed care and all of that other stuff, has nothing to do with us, from what I understand.
Yeah.
Because we're gonna have our own code and our own services that we're gonna do.
I'm gonna just say that we will be, time's up. We will take zero, but, not to cut the presentation short. This is really important, Danny, all your questions, all your, whatever, are really relevant. We are gonna be pushing out a lot more information about this because we are absolutely wanting you all to, Danny, for example, the people who've already got their certified professionals, we want them to take this exam, we want them to get state certified, we want them to become an asset to your program because we know that peers really help with retention, with recovery, with the whole life. We want to be about recovery. So we will be sending you all of the medical billing was approved on July 1st. Nobody can implement it because we don't have any state certified specialists yet. So we're gonna be having actually the whole behavioral health medical branch is going to be doing a webinar for all of our folks in the hub and spoke before you close out at the end of September. Okay. So we will be getting you all on board. Don't worry. It's it's all happening. I mean it's been like hurry up or like wait and not hurry up. And so we're kind of in that boat. But Lucero is a huge resource to us. Phil and his Voices of Recovery are going to be helping us going forward. In SOAR 3, you're going to be hearing a lot more about it. Even during the bridge funding element this whole fall, we're going to be really hitting all hard with this information. So we'll hear from Lucero. So
Thank you.
very
Thank
much.
you.
And